Thank you, Dr. Muriedio, especially for the invitation to allow me to share this topic with you. And I'm sure that it's going to be very hard, not just now, but also in the future. This subject related to the recovery of ventricular functions. For this conference, I do not have any conflicts of interest, and the issue arises mainly with ischemic cardiopathy, because undoubtedly it includes an myocardial that is in failure associated to myocardial fibrosis and several repetitive ischemia episodes. Some of them are perceived and others aren't. In clinical practice, the relevance is so practical. We have been able to identify the myocardium that will have the ability of recovering its contraction reserve. So this is the final purpose from the clinical perspective for the patients that we have to care for in clinical practice. When we see an ischemic myocardium, we see this myocardial ischemia. For example, we have this dead cell because of myocardial infarction, and it'll not be able to return to its normal function. The repercussions here is that we will have two segments in a recent repercussion, or a combined segment, which is the haze with hibernation, or that same process associated with residual significant coronary stenosis that is going to lead to these two situations from the cell perspective, which is the haze hibernated and some segments of hibernated myocardiums that are more chronic, and they're related to the surge of survival of this myocyte, so that we can believe that we can recover this residual stenosis. If we conduct this ischemia test, or for example, we have other patients coming in with ventricular dysfunction, we will find that many of them return to the myocardial function, but this is a hibernated haze, and at the end of the day it ends up being a necroptosis function or a cell deterioration that could lead to death. What similarities and what differences do we have from the mechanistic aspect in relation to this haze? Haze is an adverse event related with some sort of ischemia. We still don't have any histopathological dysfunctionalities. That means that we have the ability of recovering this myocardium if we conduct early intervention, or if we detect it in a way, and this is where the images are going to help us to improve this process of haze. And in the hibernation stage, we consider a protective adaptation to reduce the ischemic flow. In some situations it's acute, but it's mainly associated to a chronic reduction. This allows us to have the viability, and the histological changes continue to be progressive. This could progress over time if we don't have early intervention, and it could lead to a cell deterioration. And this is important because it allows us to determine the type of intervention that could lead to a possibility of reducing cell death. Therefore, an adaptation, not just cell and molecular adaptation, in the long term, it'll apply for both situations. If we want to look at the viability of the myocardium with all the methods that all of us know, you know more than I do, we can focus on the strategies of the ventricular function and the segment ability, so that we can see which areas or which segment areas could be related with stunning or chronic ischemia, or maybe we can look at the myocytes and their metabolism with some tests that allow us to identify the surge of revascularization strategies that allow us to recover the functionality of this cardiac muscle, and therefore prepare or be ready for allow them to survive. So these are the corresponding images. This is a general vision that you probably know of, but this is evidence that from the clinical perspective allows us to identify a group of patients in which our intervention, specifically in myocardial revascularization, will allow us to have a strategy to prevent myocardium dysfunction. So what is related to the myocardial viability and the role of revascularization? Undoubtedly, myocardial variability should be one of many clinical variables that should be considered when we are determining the potential benefit of myocardium revascularization. Not just the viability. For example, we look at ventricular volumes, coronary anatomy. It is important to consider the presence of valvular presences, because even if there's viable territory, the possibility of having revascularization with a valvular disease, or we could change the intervention strategy or even consider the possibility of transplantation. But something that we have to consider, which is something that many of the clinicians make mistakes in, which is any evidence of ischemia should be considered as a viability evidence. I say this because many times we have patients with proven ischemia or thoracic angina and we want to look for more viability. Maybe this is a great discussion, but this patient should go to revascularization, and it's a problem of the physicians. That it's not the problem of the imaging specialist. What is the role of revascularization in cardiac failure? In patients with cardiac insufficiency and cardiac coronary disease, they're based on three fundamental aspects. One, the presence of symptoms. Two, the possibility of having recoverable viable myocardium, and then the possibility of inducible ischemia. But we can see that the test of ischemia revaluation can allow us to change the situation for these patients. So we can improve angina pectoris, and this is not just related with a functional class, but it'll improve the cardiac functionality and it'll reduce morbidity, because we have been able to prove this when we conduct interventions in these patients. So first, we can improve the ejection fraction of the left ventricle, reduce inducible ischemia, and improve the diastolic function, that you know that it's the most important component of the ischemic cardiac disease, especially when there's no progress of systolic dysfunction. And therefore, we should reduce the symptoms of congestive cardiac insufficiency. So in which stages of the ischemic process, or when can we change the revascularization? As you can see, we have a patient with a normal heart, and we find ischemia or mild lesions in the wall. Early revascularization can lead the ventricle to not get deteriorated or to return to its normal function, because it has been very scarce in the myocardium or hibernation or regulation process. If we take an early stage where we start to see alterations with increases in the diastole in the left ventricle, eventually in some cases it could go back to normal, or in other cases this remodelation could be less aggressive. If we start late phases, the intervention of revascularization, we can achieve some recovery, but we cannot get to the normal state, and we have a harder point, which is the advanced stage of the ischemic process, where we can have adverse remodeling and hibernation processes. And this is where the question would be, should we do revascularization in these patients? And this is the great question for advanced cardiac failure patients, and therefore we won't be able to have a proper benefit with our intervention in revascularization. What is the evidence of myocardial revascularization in the left ventricle? If we look at this meta-analysis, we see a large number of patients evaluated with myocardial revascularization and only left ventricular dysfunction. We were trying to see the possibility of they had myocardial viability. Some of them had a proven ischemia or angina, and we compared surgery revascularization, cutaneous treatment versus clinical treatment. And you can see that surgery revascularization in comparison with medical treatment was better than with patients, and you know that these are high-risk revascularizations. Other types of angioplasty or any revascularization strategy would be superior. And when we have myocardial revascularization with myoplasty, this was slightly higher, but the myocardial revascularization was better because probably the intervention in this group of patients, as you might see here, was above in comparison with angioplasty with percutaneous intervention, and probably because myocardial revascularization allows us to have a potential recovery of a greater ischemic territory, even if it's identified or not. In this case, remember that in this group of patients, it wasn't determined by previous tests of myocardial viability. What evidence do we have of myocardial revascularization in the left ventricle with proven myocardial viability? If we look at the clinical studies of revascularization with evidence, and some of these myocardial viability evidence, we see an improvement of 8% of the left ventricular function. You might say that this is little, but when we look at our cardiac insufficiency in our clinics, the average improvement rate that we can find, excluding the cardiopathy groups that have a higher level of recovery, this is the average of recoverability that is not bad. And actually, we have to consider the results above the ejection fraction. We found 185 patients of all these trials in which we have determined viability, and we found an improvement of those with viability in comparison with those that didn't. We had an improvement in the volume of the systole in the left ventricle, the volume of the diastole in. So these are relevant improvements, statistically speaking. They're significant, as you can see here, in patients with left ventricular dysfunction and myocardial viability that has been previously documented. In this meta-analysis, we can see the need of myocardial viability in this group of patients. We can see how death or the mortality of the patients with the left ventricular dysfunction in those that had viability in comparison with the medical treatment was a statistically significant reduction. And these modifications of the guides back then, considering the need of using in this group of patients a evidence of viability that would allow them to identify the group of patients that would be benefited with revascularization. If we look at STITCH, this was a group of patients, and people wanted to see if the surgery of a bypass, cardiac bypass of ischemic origin would allow to reduce mortality rate in these patients. So mortality is evaluated for all causes, for cardiovascular reasons, and deaths due to hospitalization and cardiac failure. So what we saw in the past 3 months, the idea is that they would have a coronary disease for surgical revascularization susceptible of being taken to an intervention process of revascularization. So this is the randomized group for the treatment, and this was the randomized group to these different trials, 22 countries, and it started in 2002 and it started in May 2013. What did they find in relation with mortality? Because of all reasons, they didn't find any statistically significant differences between the medical treatment and the myocardial revascularization treatment. They didn't find any differences that would be statistically significant in relation with medical treatment and revascularization in cardiovascular mortality. In death and hospitalization because of cardiovascular reasons, there was a significant different result. Those with myocardial revascularization, they survived at the beginning, and a reduction in mortality because of all the cases for all patients who were taken to revascularization. But if you see here, the initial peak was an increase of initial mortality. That means to take a patient of higher risk to myocardial revascularization in the initial phase had a higher risk for mortality, but in the end, the causes were lower in this group of patients. So which were the limitations of this study? First, it was not blind. The patients were pretty much selected at the criteria of the physician. There were no fatal results randomized, and the strategy of viability was conducted afterwards, and therefore it did not allow to determine if by handpicking the patients was clear or not. So if we would have selected them with myocardial viability test to determine what group of patients was useful to take the results from. Despite this, the characteristics of this study were very well treated, especially up to 2007. Of course, now we have better treatments. So these were patients that were in serious condition. As you know, cardiac failure globally, 1 out of every 2 actually die in the course of 2 years. So in these patients handpicked, these randomized patients, there wasn't any mortality specifically to any reason, and the medical treatment with myocardial revascularization reduces the cardiovascular death in comparison with just the medical treatment. So there were some advantages when they're randomized, but the patients are subject to an early risk of mortality because of the conditions and the characteristics of these patients. This meta-analysis shows the effects of revascularization versus the medical treatment in mortality because of all cardiac death reasons. In non-randomized studies, they just took all the studies that evaluated this possibility in relationship to revascularization. And we see a superior revascularization both for angioplasty and medical treatment, and those that had negative viability did not show any statistically significant differences. You know that from the statistical perspective or epidemiologist perspective, this is not sufficient, but in some patients with viable territory could have been useful for revascularization in these patients. We could say from this meta-analysis that the presence of viability identifies patients with high risk of events if they are not revascularized. But because of its design, it doesn't allow us to define whether to guide the presence because of viability. We don't know if it'll choose the prognosis of the patients. It only gives us an idea in this sense. If we look at the effects of revascularizations because of mortality for all reasons and cardiac mortality in all control studies, we see that those with viability had a statistically significant difference in control studies with a lot of reserve because these studies have a lot of reserve. The available information concludes then that in relation with the use of myocardial viability in the decision-making process with relation to the left ventricle revascularization and coronary disease, those patients with viability seem to be benefited from revascularization. But these same benefits were also seen in patients without a viable myocardium. So we start to say it's useful, it's not, we don't know it. What is the certainty in relation to this? However, a neutral effect or adverse revascularization effect cannot be excluded in any of the groups because the way in which we took these strategies were different. We can see these are the control studies, the STITCH, HEART, PAR, all of them were differentiated with different strategies of proving myocardial viability. They did not show any statistically significant differences, but when we make the comparison with the mortality rate, annual mortality rate, in those patients with viability of these clinical studies, we do not see any statistically significant differences. There was in the meta-analysis, but there weren't statistically significant results either. It doesn't tell us anything, and this group of patients starts to propose difficulties. So why do we still have to define the limitations? As you can see, the PAR study that we thought that was going to help us with viability aspects, it was limited by the adherences to the recommendations of which myocardial viability strategy should be indicated. So every person pretty much chose the one that they want. There was no indication of which parameters should be used to determine myocardial viability. In part, there were many limitations also for the patients, and they lost statistical power for the results. And in STITCH, the viability tests were also not randomized. And therefore, since they were not randomized, the doctor would decide if this one would have to have viability or the other wouldn't. So if based on this principle, what would happen with the surgery then? Therefore, it's not a study that doesn't use viability as a theoretical strategy to arrive at these conclusions. So what are the conclusions so far? First, the recovery of the contractibility study in a hibernated case is uh, determined by these control studies. In randomized studies, we haven't had any significantly difficult results, despite all the difficulties for us to arrive at a final conclusion. Solid information in control studies so far that are available in the presence or of a viable myocardium. This is considered together with other clinical factors for decision making in the handling of patients with ischemic cardiopathy. Of course, we have to be clinicians above all for all decision making for our patients and not just basing on a result of an image. The theory of ventricular function is multifactorial, and it could be analyzed in isolation because of the viability images. Because for many patients that didn't have viable territory, we still have many discussions about them, about the potential benefit that they could have. Therefore, the myocardial revascularization decision should not be taken in isolation without the presence of viability. What are the recent recommendations with left ventricular dysfunction patients? First, we recommend viability images either with PET or SPECT or with echocardiogram to look at the size, the function, thickening of the wall, association with other pathologies, for example, valvular pathology that modifies the surgical intervention strategy. We can wonder if the patient has a viable myocardium. Revascularization does not predict better results than a medical optimal treatment in those patients who don't have it. At least we have to look at the available evidence. And those patients with viability would it increase above the medical optimal treatment? And does revascularization improve results in the myocardial function? And therefore, this group of patients could be recommended for the therapeutical intervention. What are the factors that affect? And this is where the clinician plays an important role. If we look at these different color matrices, the probability or the trend for the medical treatment to be better would be directly related to other clinical factors. They were advanced. Probably we can see it as a medical treatment than to submit them to a complicated surgical procedure. More intervention of the ventricular function. Maybe that person will do better with medical treatment than with surgical treatment. And as we go down, we will have more probability for having surgical treatment above the therapeutical strategy in association with revascularization. And the viability as a plays an important role to consider therapeutic strategy in these patients. So what do the guides say? They have to contribute with something, and they say this based on the evidence. If we look at different guides, this is the guide of the Cardiothoracic Association in Europe, and as you may see, myocardial revascularization in thoracic or equivalent thoracic, this is first with SPECT recommendation level in patients with cardiac insufficiency. Why? Because the territory at risk is significant. We wouldn't have to see if there's viability or not, but we have to look for a way to revascularize the patient. Revascularization in angioplasty, if the myocardium is viable, will give us an evidence of 2A with a recommendation level, which means that a level of evidence 2A, it means that if I don't do it, I have to say why I didn't truly do it, and the possibility of myocardial revascularization. The cardiac failure guides of the American Association of the American Heart show that revascularization improves mortality, and it's reasonable in patients with mild to moderate ventricular dysfunction or when the viable myocardium is present. So there's a level of evidence, and we can see this could not apply when the clinical studies are going to be the same. So myocardial revascularization can be considered in patients with left ventricular dysfunction that is severe and surgical operable anatomy. Coronary anatomy, and the level of evidence to be is harder for decision making. When do we consider this? When the patient looks like the clinical study that gave us positive studies, and this would be when the recommendation could be more appropriate for our patients. This is the guides of revascularization failures in Europe, level of evidence 2A as well. So all the handling guides match in intervention for these type of patients, and angioplasty in those in which surgery would not be indicated, because these are high-risk patients and they're susceptible of suffering some type of myocardial revascularization.